Good evening, friends and viewers. Why there is always good morning, there has to be a good evening as well. So, I'm coming with you on the new lecture, Lung Cancer Overview. This lecture is entirely focused on the undergraduate students and then first year, second year residents of clinical oncology, and I'll be going through the just overview of a lung cancer. Will not be very deeply focused about the radiotherapy planning. Will be coming on the next lecture for a radiotherapy planning. So myself, Major Dr. M. Kubeg, radiation oncologist, JK Cancer Institute, presenting you before lung cancer overview. Dear friends, kindly encourage your juniors and a colleague and your friends. So subscribe this channel, Major Dr. M. Kubeg oncology classes. You'll be getting a much more in the coming futures, like radiology of head and neck, thorax, abdomen. What about the CT, ultrasound, and MRI, etc., which I'll be coming in the very soon. So let us start the lung cancer overview. The histologically lung cancer is being divided into two different categories: differentiated lung cancer, undifferentiated lung cancer. The undifferentiated lung cancer is differentiated lung cancer is a squamous cell carcinoma, adenocarcinoma, in which the squamous cell carcinoma dominates. Adenocarcinoma is only 20% and squamous cell carcinoma 50%. And when we see the undifferentiated carcinoma histologically on cell lines, the small cell carcinoma merely consists of 15%, and the large cell carcinoma 15%. So almost, if you categorize the differentiated versus undifferentiated, almost 70% lung cancers are differentiated carcinoma, and undifferentiated carcinoma are only 30%. The WHO has divided, broadly speaking, and the non-small cell lung cancer and the small cell lung cancer, in which the small cell lung cancer almost comprises around 85% cancer, which is more dominating and more very common occurrence among the oncology, and the small cell lung cancer. Why I'm talking about the lung cancer overview? Because the lung, in the recent data from the Indian Council of Medical Research, says that the topmost cancer in India is a lung cancer. That's surpassed all the cancers and gone on the top. So non-small cell carcinoma further divided into the squamous cell carcinoma, adenocarcinoma, and then these are the squamous cell carcinoma further ramified in the epidermoid type, spindle type, and mesothelioma type. Adenocarcinoma are acinar type, papillary type, bronchoalveolar type, and in small cell carcinoma, oat cell, intermediate, and mixed variety. So the lung cancer regarding the squamous cell carcinoma variety, that you have seen the 50% of differentiated cancers are the squamous cell carcinoma. They mostly arise from the proximal bronchi. Because of availability of squamous cells to exfoliate, this tumor can be detected by the cytological examination at the earliest. Because it is arising from the proximal bronchi, then you must understand that by bronchoscopy examination or a sputum examination for a malignant cells, cytological examination, you are having a high chances of getting the positive malignant cells in this variety. The second features, the squamous cell carcinoma having a best survival rate, and it's strongly associated with the cigarette smoking. As well, I've already told you the 50% of all lung cancer is diagnosed as squamous cell carcinoma. You see here the squamous cell carcinoma arising from the proximal bronchi. In the chest X-ray, you see on the left perihilar region, you see the lung mass irregular, and that itself indicates that this lung mass is having an irregular shape, opacity. By chest X-ray, you cannot very much go into the depth of its radiological imaging, but you can see here the proximal bronchial, there is a mass lesion which almost pushing the trachea towards the opposite side, that means on the right side. So this mass lesion is typically proximal bronchial lesion is squamous cell carcinoma, usually found in this picture. And then the closest DD in the among the oncology is the almost the small cell carcinoma. They also arise from the proximal bronchi. You see here in this CT scan image, this CT scan lung window image, you see here on the proximal bronchi there is a mass lesion, and at the level of, you see the carina, the trachea is bifurcating in the two sides, on the right and the left side. On the right side, you see from the principal bronchus, this mass lesion is rising. There is no as much, you see the lymph nodes, there is nothing lymph node there here in this. Also you can see beautifully the aorta, and in the closest vicinity of aorta, the thoracic duct you can see, and you see the lung window absolutely clear both the sides. There is no nodules on the opposite lungs as well. So it's an early lung cancer carcinoma, and usually squamous cell variety until unless it is proved by CT guided FNAC. So there is a other variety of non-small cell carcinoma, that is adenocarcinoma. Almost 20% of all lung cancer are adenocarcinoma of lung. Because of these, tumor arise mostly from the peripheral surface epithelium or bronchial mucoid gland, seen on the X-ray as a peripheral lesion. So the lesion here you get on the periphery. On the X-ray you get, and then CT scan you done. It is not like a squamous cell carcinoma on the proximal bronchial lesion. It will be distant from that. It will be on the peripheral lesion. So in the peripheral lesion, you mostly see the adenocarcinoma, and the differential diagnosis in the oncology, that's a large cell carcinoma, but mostly adenocarcinoma. A variety of adenocarcinoma also called bronchoalveolar carcinoma. What is this bronchoalveolar carcinoma? It's basically adenocarcinoma which arise from the type 2 pneumocytes in the lung. What are the type 2 pneumocytes? These are the types of pneumocytes which secrete the surfactant. And metastasis in adenocarcinoma may occur in the liver, bone, brain, adrenal gland, as having a poor prognosis as compared to squamous cell carcinoma. You see here in the lung, trachea is absolutely central, but you have the peripheral bronchial lesion on the right side of the lung, as the arrow shows. So you predict the diagnosis must be adenocarcinoma unless proved otherwise. Why I am telling? Because you cannot see on the imaging confidently that it's a lung cancer or something else. So you have to go for FNAC. So adenocarcinoma may secretes also growth hormone, corticotropin, calcitonin, follicular stimulating hormone, luteinizing hormones. And because of these, there are certain features developed in an adenocarcinoma. Also, they shows the hypertrophic osteoarthropathy. Arthropathy more commonly occurs in adenocarcinoma variety of lung cancer. Adenocarcinoma has a worst stage mass prognosis compared to the squamous cell carcinoma. Metastasis adenocarcinoma, I have already told you. Then again, there's a non-small cell lung carcinoma variety, the large cell carcinoma lung. It constitutes about 15% of all lung cancer. It has two kinds. Large cell carcinoma has a giant cell variety, very, very aggressive tumor, and then a clear cell type. It's again a very, very dangerous so far as the prognosis is concerned. So why it is called clear cell? Because they have a clear cytoplasm. And then 50% of cases of a large cell carcinoma patient develop brain metastasis. You can imagine how fast this tumor grows on, and almost considered to be a systemic disease. However, its metastatic pattern is similar to adenocarcinoma. You see the large cell carcinoma image in the CT coronal image. You see it's again at the peripheral lesion. This mass lesion at the level of carina again here. You see the almost infiltrating the rib on the left side, and Trachea, you see the trachea bifurcated in the right and the left bronchus, and this is lesion is large cell lung carcinoma unless until proved otherwise. A lot of things. Now I'll be telling you about this small cell carcinoma. The 15% of all lung cancer are small cell carcinoma. That's so you can see that if you decide on the lung cancer, the small cell carcinoma occurrence is a little lesser in compared to the non-small cell carcinoma, because non-small cell is almost 85% cases. So the radiological picture of a small cell carcinoma almost similar to squamous cell carcinoma, since both present the central lesion in the CT scan or lung X-ray. But a small cell carcinoma is highly malignant tumor involved very early to the hilar and mediastinal lymph nodes, and metastasis do occur by lymphatics and vascular both channels. So you see, because of a high metastatic region, by lymphatic and vascular channel both, so that it involves very early to hilar mediastinal lymph nodes, and then in mediastinal, large mediastinal lymph node and proximal bronchial region. This indicates the proximal central lung mass lesion on the X-ray, and then we can differentiate the mass lesion and the lymph node in the CT scan. At the time of diagnosis, most of the squamous small cell lung carcinoma patient do have a distant metastasis, and that is the reason why typical TNM staging is not used in this small cell cancer, because the patient is almost TNM is basically given by UICC because of to assess the operability, also to assess the operability by the surgeons. But this patient is having almost a distant metastasis. The probability of operating this kind of a tumors is remote. That's why typically not used here. You see here in the picture the lung small cell carcinoma arising here, bronchi, proximal bronchial, and you see here in both the sides in this image, courtesy Adam. But in this X-ray image, you see on the right side the mass lesion, a central mass lesion. But on this, on the contrary, opposite side, that's having a bilateral lung lesion. Here you see the small cell lung carcinoma, the central lesion with a large necrotic mediastinal lymph nodes as well. And multiple nodules you see on the opposite side, calcified nodules in the lung, and there is also necrosis present in the center of the tumor. It indicates the very aggressive variety of a tumor. So spread of lung cancer, there are three methods of spread: direct spread, lymphatic spread, hematogenous spread. So direct spread, it's involved the lung, adjacent lung parenchyma, the contiguous spread to the pleura overlying the lung parenchyma. It involved pulmonary vessels are involved, aorta is involved, chest wall involved, ribs involved, serratus anterior muscles and ribs involved, and ultimately recurrent laryngeal nerve and a phrenic nerve involved because of a large mediastinal lymph node or a tumor, proximal bronchial tumor, causing a pressure effect on recurrent laryngeal nerve and a phrenic nerve. And you can see clinically in the radiology, as well as asking the patients to phonate and tell something that a change in a voice is an indication of a recurrent laryngeal nerve. And the diaphragm of that side of the lesion is up, phrenic nerve is supplied. So the diaphragm in the X-ray, you see the uprise in the radiology. So lymphatic spread, it's paratracheal lymph nodes, which is closest to the bronchi, hilar lymph nodes. First involve, however, the direct mediastinal lymph node involvement may occur without involvement of hilar lymph node. This phenomena is called skip metastasis, which is found almost 30% in case of a lung cancer. Usually, the lung cancer or any cancer metastasizes through the very systemic pathway, like one lymph node, then nearby lymph node, then the final lymph node. It goes through the chain. But you see here in the lung cancer, in the 30% case, without involvement of the hilar, directly tumor goes to the mediastinal lymph nodes. A usual chain is they involve first the hilar lymph node, then it involves mediastinal lymph node, and then further goes to the supraclavicular lymph nodes. But in the 30% cases, they skip metastasis there. Hematogenous spread most commonly occur through pulmonary vein and to opposite lung. So the opposite lung is a type 4 disease because it is systemic metastasis. Otherwise, organ like brain, liver, bone, adrenal gland, these hematogenous spread occur. For a simplification purpose, I have this thing for a students of undergraduate level. I have classified this lung cancer. You can see when a growth on the limited to lung parenchyma, you say it is a stage 1. But the stage 2, if a growth involving the lung parenchyma as well as hilar group of lymph node is involved, so you can say the patient in a stage 2. If mediastinal lymph node involved, then the patient is in a stage 3A. And students must remember, for seeing the hilar lymph node, chest X-ray PA view is sufficient, but for seeing the mediastinal lymph node, you require a lateral view of a chest X-ray, because in this view you cannot see the mediastinal lymph node by chest X-ray traditional PA view. You require a lateral view to assess the mediastinal lymph node. And the stage 3B, when it is 3A mediastinal lymph node involved, and when it belongs with the chest wall or the side of the lung, that is stage 3B, and a stage 4 is the opposite lung and distant metastasis. But for the clinical oncology students, little more complicated staging system, AJCC8 lung cancer staging system says the T1 tumor size is less than 3 cm or 3 cm. T2, when a tumor size is 3 to 5 cm or involvement of principal bronchus. If only principal bronchus involved, it becomes a T2 lesion, or the tumor size is 3 to 5 cm. T3 is a tumor size 5 to 7 cm or tumor involving the chest wall and the pericardium both. A T4, a tumor size is more than 7 cm or it has involved the mediastinal, recurrent laryngeal nerve, cervical lymph nodopathy. So you can say it is a T4 lesion. So if you get a patient is a change in a VAS of a lung cancer, recurrent laryngeal nerve involvement is stateway, the stage is T4. Just asking the history. Or mediastinal lymph node involvement, that's T4. Regarding the nodal system, N1 ipsilateral hilar lymph node involved, N2 ipsilateral mediastinal lymph node involved, N3 contralateral hilar or mediastinal lymph node involved, or a cervical lymphadenopathy. A patient is having a supraclavicular lymph node or a cervical lymph node, that is stage 3. M1A is a single solitary extrapulmonary metastasis, M1B multiple extrapulmonary metastasis. Why M1A and B? Because you see the importance of this, because there is a chances of oligometastasis, a single solitary extrapulmonary mets, or a metastasis, a smaller metastasis less than 5 in number. Then there is a concept of treating the oligometastasis disease, a new concept by smart RT like SBRT and etc. So the symptoms in the lung cancer, the most common symptom is what? For students, the UG undergraduates, only dry cough, no chest pain, no hemoptysis, nothing. And the patient is having a long-standing history of a dry cough since around 2 months or 3 months. You must first diagnosis should be the tuberculosis, and then the second you must click that it might be a lung cancer. Dry cough, hemoptysis, chest pain, dyspnea, wheezing, stridor, these are the pulmonary symptoms. And the extrapulmonary symptoms, you see the hoarseness of voice due to pallidosis of vocal cord because of laryngeal nerve paralysis, and as well as mediastinal lymph node large involvement leads to the superior vena cava syndrome. Also pain down the arm due to involvement of a brachial plexus. Horner syndromes occur in the lung cancer due to involvement of superior sympathetic chain. Dysphagia also occurs due to large paraesophageal due to paraesophageal nerve involvement and due to large paratracheal lymph nodes. Phrenic nerve involvement lead to the diaphragmatic paralysis. And what are the extrapulmonary metastatic symptoms like brain metastasis present with the patient present with the hemiplegia, fits, headache, vomiting, confusion? These are indication of a patient is having a brain metastasis. Lung cancer also present with a paraneoplastic syndrome. What is paraneoplastic syndrome? Because of some excesses of hormone secretion occur because of lung cancer. These extrapulmonary non-metastatic symptoms are due to excess of corticotropin secretion, excess of ADS secretion lead to hyponatremia, hypokalemia, and hypercalcemia. You get a clubbing, acanthosis nigrans, migratory thrombophlebitis, Trossius signs. What is migratory? When the tumor tissue basically lodged through the vein, the different vein from the primary site, and then you go thrombophlebitis, recurrent, migratory, different sites of the body. This is called Trossius sign, which is there present in the lung cancer. So till now you have gone through the depth of overall general view of lung cancer investigation, presentation, presentation and types of a lung cancer and histologically how it behaves. So I'll be now switching over to investigation of a lung cancer. So what are the investigation we require to do? The chest X-ray. Once you see the hilar lymph node, mediastinal lymph node, lung mass, evidence of bronchial obstruction like collapse, consolidation, pleural effusion, suppose right side of the principal bronchus is involved, so there will be a collapse in the lung. So these are the features are present. Elevation of a diaphragm suggestive of phrenic nerve palsy. I've told you that that side of the diaphragm will be elevated. But you must know that the chest X-ray, when the lung cancer is detected in the chest X-ray, then it has gone almost crossed the 75% of its natural history. Means the patient is locally advanced stage. For picking up the very early lesion, you require a CT scan, because on the chest X-ray, if you see the lesion, that means lesion is large enough to has crossed the 3/4 of its natural history. So radiological picture of a different type of lung cancer like a lung squamous cell carcinoma on X-ray more commonly present with the collapse, consolidation, reason because of proximal bronchial lesion which cause collapse or a consolidation. In adenocarcinoma, X-ray more often present with the peripheral mass lesion. The obstructive bronchial lesion is less common. Large cell carcinoma present like adenocarcinoma, peripheral bronchial lesion, so the collapse and a consolidation is less likely here. The small cell carcinoma in 80% cases present with a hilar abnormality and a central lesion. Henceforth, the squamous cell carcinoma, the X-ray picture is like similar to the picture like a squamous cell carcinoma here in the small cell lung carcinoma. So that you go for a cytological examination, that what are the cytological examination you can go? First is the sputum cytology, positive in 60% cases of squamous cell carcinoma due to exfoliative nature of squamous cells. And the patient cough, you send the sputum for the cytological examination of malignant cells. Then if it is a histology is a squamous cell, then in 60% cases you are likely to get in a positive results. The squamous cell carcinoma involving the proximal bronchial lesions are more likely to come in the sputum, but in the adenocarcinoma, lung sputum chances is less likely to be positive due to peripheral lesion. If a lesion in the periphery, then if patient is coughing, that is less likely to come in the sputum, the malignant cells. So that you can understand. There is also chest X-ray. After that, you also go for a CT scan. But I have here the slide showing the bronchoscope examination. Fibro-optic flexible bronchoscope with the help of a direct visualization of tumor, as well as your biopsy you can take from the, and in the, if the lesion is central like a squamous cell carcinoma, a small cell carcinoma, you can get an accuracy of 90% positive results in the bronchoscopic examination. But if lesion is a peripheral, the accuracy drops down to 45%. Why? Because the bronchoscope does not go up to that length to see the peripheral lesion, but the proximal lesion in the bronchus, it can be easily picked up by the bronchoscopic. You can see the visual, and as well as you take a biopsy from the lesion. You see here the flexible bronchoscope. It is connected with a monitor, and then put through the laryngoscope, with the help of laryngoscope, to the bronchus and the trachea and then the bronchus, and then you see the image of this thing. So what you get in the flexible fibro-optic bronchoscopy is not just to visualize the tumor, it's just not to merely limited to taking a biopsy from a tumor. There is a series of information you can get with that flexible bronchoscopy. What are the vital information you get? We can get a length of a normal bronchus proximal to the tumor, so that you can help in planning of a lobectomy. So if the CTVS surgeon is planning for a surgery, early lung lesion, then the bronchoscopy is very helpful, because it picks up the length of proximal to the tumor. Bronchoscopy, you see the status of a carina. If a carina is widened enough in the bronchoscope, while taking out the bronchoscope, you can see the status of a carina. Say if it is a widened carina, that means the subcarinal lymph node is there. And also while coming out, that you can see the vocal cord palsy indicate the recurrent laryngeal nerve palsy, that indicates the tumor is inoperable. So these are the information you get with this. FNAC investigation of a lung cancer is ideal when the tumor is in the peripheral and you are not getting the sputum cytology positive, or you are not getting with the bronchoscopic examination by the assisted biopsy. You cannot get a high result. So the CT guided FNAC is done, and by the help of the CT you can see the depth and the angle by which you needle introduce, and then you take out this thing. And more preferably, if you go for a core needle biopsy, it is very important, because you need to assess the receptor status, because there are multiple targeted therapies are evolving nowadays. So if you have a biopsy reports, you can go for a detailed examination of the receptor status, and then according to you can plan the treatment, sequencing of a chemotherapy and along with the targeted therapies. The CT should have been be told by you people on just after the X-ray, but here slides are little misplaced. So anyway, the CT should be done after the chest X-ray to see the primary tumor along with the hilar and mediastinal lymphadenopathy. The sensitivity of CT is to pick up the 1 centimeter lesion. It's very sensitive to pick up 1 centimeter abnormal lesion. And also CT gives an idea about the tumor infiltration to the major vessels. And the CT also helps to see the opposite lung parenchyma, and how further helps CT guided FNAC or core nodal biopsy. So these information you get in the CT scan. So you see here the CT guided FNAC, how we perform, and the CT scan you see here where is the tumor, what is the depth of a tumor, what is the angle by which the needle is placed, and after placing the needle you can match it. If the needle is in the proper tumor, you take out the specimen. You see here the lesion lung carcinoma where the needle is passed. You see here the needle is right in the tumor on the left side of the coronal image of a CT. You see here, and the needle is being passed here, and a sample is taken. So now treatment of a lung cancer, all three modalities in oncology like radiotherapy, chemotherapy, surgery used in a lung cancer, now further added with a new era of targeted therapy extensively used for the lung cancer. The treatment of non-small lung cancer, because it comprises of almost 85% of lung cancer, is stage 1 and 2. You can think of a surgery in form of lobectomy and pneumectomy, but lobectomy or a segmentomy is preferred rather than pneumectomy, because having a pneumectomy having large complications. But before the surgery, what you require to do, the pulmonary function test, forced expiratory volume, one should be more than 1.2 liter, means FV1 by FVC ratio, functional vital capacity and forced expiratory volume ratio If it is less than 75%, indicates obstructive lung disease and patient not deemed suitable for surgery. The breath holding test, it should be more than 20 seconds. ABG should be done, arterial blood gas level. Immediately you can say the 90% saturation. Peripheral pulse oximetry saturation 90%. ECG echo for cardiac function. Ejection fraction must be more than 60% in echo. So these are required the cardiorespiratory test before putting the patient for a major surgery. You can see here, if as much as the specimen is removed, like segmentomy, that total involved portion of a segment is removed. So that's a minimal surgery. The complication rate is 10% mortality. Complication rate is 10% and mortality rate is 1.3%. But if a large specimen like a lobectomy is you are doing a lobus, particular lobus to be removed, then a complication is 15%, mortality raised from 1.3 to 2.9%. If a pneumectomy is done, which is remotely done nowadays, complication raised 15%, mortality is 6.2%. So why the patient do not get a surgery? Because the X-ray, the patient present in a locally advanced stage, not being suitable for a surgeon to go for a surgery. I hardly you see in the oncology department the patient who come for after the surgery for a chemoradiotherapy. I hardly see any patients, usually almost 4 or 5 years or 10 years you get in one or two patients who got operated. So why not surgery is done? Because the patient landed with a recurrent laryngeal nerve palsy, phrenic nerve palsy, mediastinal lymphadenopathy, opposite lung involvement, patient is superior vena cava syndrome stage, growth involving the tracheoesophagus, chest wall erosion, distant metastasis, growth present in the principal bronchus, patient having a poor lung function or cardiac function, patient having a pleural effusion. These are the features are a contraindication for surgery. But usually you get with these features in patient of lung cancer. So the surgery is a remote possibility. So if surgery is not done, what is doing? That's a clinical oncologist intervention strongly here. And a medical oncologist. The locally advanced non-small cell lung carcinoma 3A, 3B, inoperable tumor required radiotherapy and a chemotherapy. That I have told you. Brain metastasis treatment usually occur in 30% cases of non-small cell lung cancer. And lung metastasis are typical in the lung cancer. Brain metastasis is typical, that is single and solitary. Contrary to the breast metastasis, there are multiple enhancing lesion in the brain. That is a breast cancer CT brain. But in the CT brain of a lung cancer, you usually get a single solitary mets. So we can use the whole brain RT, can increase the survival more than 6 months by giving a 20 gray 5 fraction or 30 gray 10 fraction. However, if a single solitary brain metastasis is there, you have a highly good gamma knife or X knife, you should go for a stereotactic radiosurgery so that you can save the other vital brain structures. And adrenal metastasis occur in 30% of lung cancer patients. So radiotherapy in lung cancer, in traditionally conventional radiotherapy is non-small cell lung cancer, 60 gray 30 fraction is used. The contraindication must be very, very clear where not to use the radiotherapy. And then a 15 millimeter margin given in the craniocaudal direction and 6 millimeter margin taken for the transverse direction. Those who are treating the patient with not image guided or a very sophisticated radiotherapy department have a cobalt, a traditional cobalt and 6 MV linear accelerator. This margin is given. Otherwise, you get there are various evolving radiotherapy and evolved even the radiotherapy by like SBRT, like giving and then image guided radiotherapy in case unconformal radiotherapy for non-small cell lung carcinoma with a better results. Brachytherapy role in the lung cancer can be used alone or in combination with external beam radiotherapy as a booster, indicated when the hilar lymph node is adherent to the major vessels, attachment of tumor with a mediastinal structure, chest wall involvement, or spine or paravertebral tissues are involved. So that with brachytherapy we can give the HDR with 6 to 7 gray per fraction, total dose 15 to 20 gray means, we can use the 7 gray 3 fractions traditionally for HDR with the help of a bronchoscopy. Brachytherapy catheter is being passed. You see the conventional lung radiotherapy, the tumor, we linear accelerator we give, and in the downside you see what is the downside is there, that is EPID, electronic portal imaging device. We image the tumor during the radiotherapy so that you can counter check and counter check, image verification, and then you can do a correction. So here see the hilar tumor, and then a field, traditional cobalt field is used in the hilar tumor involving the opposite side of the hilum as well. And you see the conformal radiotherapy in case of lung cancer. You see the multiple beams involving covering the tumor more than 95% with sparing the spinal cord and the lung as a critical target organ and the heart, so that we can deliver a good amount of radiotherapy. You can see here the brachytherapy, how we use with the help of a bronchoscope. These are the brachytherapy channel. You can see here the multiple channel brachytherapy used for can be used as a high dose radiotherapy to the lung cancers, as an adjuvant to the external beam radiotherapy, as an indication as already mentioned. The role of chemotherapy in lung cancer is cisplatin, etoposide, paclitaxel, carboplatin, but it's not. There is a gambit of a range of chemotherapy available for the non-small cell lung cancer. Also, some advanced chemotherapy like bevacizumab is there, the anti-vascular endothelial growth factor receptor inhibitors. They are used here with the good results. The recurrence of a non-small lung cancer within the lung is 30 to 50% do occur, and the distant metastasis occur in 30 to 45% cases. The adenocarcinoma and large cell carcinoma do have a tendency to recur with a disseminated disease, contrary to the typical squamous cell carcinoma. They have a lung recurrence, local recurrence in the lung area is very high in a squamous cell carcinoma, but adeno and large cell carcinoma, they relapse with a disseminated disease. So little bit about the small cell carcinoma, because it consists only 15% of lung cancer, but it's a very, very aggressive tumor, very fatal tumor. Almost 50% to 60% tumors show complete response with the chemotherapy. They present with a very high response to the chemotherapy, contrary to squamous cell carcinoma. It's also associated with the smoking. If small cell carcinoma left untreated, its median survival is limited to only 3 to 6 months. Though the small cell carcinoma location is at submucosal, but malignant cells in sputum due to exfoliative nature is high cytological positive results, like in typical squamous cell carcinoma. I've already told you that TNM imaging not used in small cell carcinoma, since these tumors usually do not undergo surgical resections. The reason is simple, because the systemic disease, squamous cell carcinoma spread very fast to the regional lymph node, distant metastasis. So, and there is a entity called prophylactic cranial irradiation, because there's high chances of brain metastasis. So prophylactic cranial irradiation is given once the patient is stable, given a full course of chemotherapy and there is no lung lesion, which reduce the lung probability of brain metastasis from 25% to 5% only. Sometimes with very limited disease to the lung, we can go 40 to 50 grade to the primary tumor by external beam radiotherapy. Thank you very much. It's long exhausting lecture. Thank you for listening, my dear friends. But you go repeatedly listen this lecture on your mobile phone, so you'll get a very, very good information, and you'll have a very clear-cut idea. For our clinical oncology students, I promise you I will be back with a more advanced radiotherapy planning in the lung cancer in maybe after my commitment in the North Zone ARI presentation. After that, I'll be fetching you all guys. Until now, kindly subscribe this channel and encourage your friends to subscribe this channel so that we also get encouraged, so that we'll be giving you plenty of informations regarding the oncology. And then the first thing I'm going to hit is the lung cancer advanced radiotherapy planning. Thank you very much.